Okay guys, our fourth video on pulmonary dysfunction. We're going to kick it off by talking about respiratory tract infections. All right, so we've got acute bronchitis.
Professor Reed, drinking and learning don't go together.
Obviously, this is an acute infection. We had just discussed chronic bronchitis as a chronic inflammatory issue. This would be an acute infection and accompanied by inflammation. Most of the time, excuse me. These are viral in nature. The treatment for these, because they're not chronic conditions, would be things like rest, NSAIDs for pain, humidity, and cough suppressants where appropriate. If it's bacterial, antibiotics. Okay, so let's talk about pneumonia. Pneumonia has gotten some press lately, as it is, many people have been talking about pneumonia along with the COVID-19 virus. Okay. What happens when someone has pneumonia very generally is they have an infection or an issue in their lower respiratory tract that can be caused by things like bacteria or a virus or a fungus or even a parasite, okay? And that's going to allow for inflammation and fluid accumulation in the lung. And obviously that's going to cause some significant respiratory distress. Some of the risk factors for pneumonia are age. I love that age is a risk factor for everything, but as we get older, we all understand that age alone puts you at risk for certain issues. People who smoke. Jake's trying to contribute to the lecture.
You know I'm correct.
Compromised immunity.
Shopping every day.
People are immunocompromised, people living in closed quarters. As we mentioned before, people with impaired swallowing have a tendency to develop aspirational pneumonia and intubation. Okay. When we talk about pneumonia, so you can have, as I mentioned, you can have something bacterial in nature or viral, or it can be fungal or parasitic. We're talking bacterial. Is the most common is probably pneumococcal pneumonia, which is interesting because pneumococcal pneumonia, there's actually a vaccine against a bacterial condition. Most of our vaccines obviously are against viral conditions, which is very interesting. Viral pneumonia is one of the more popular and more common community-acquired pneumonias that you see in places like nursing homes where you have a lot of older immunocompromised individuals occupying very close quarters. Okay, symptoms and signs of pneumonia would include things like fever, chills, difficulty breathing, pleural pain. But one of the hallmarks of pneumonia, something that physicians will listen for when they're trying to assess somebody to see if they have pneumonia, is what are called inspiratory crackles. So it's a very distinctive sound that you would hear when you would listen to someone's lung sounds using a stethoscope. Okay, because it's infectious in nature, someone would have an elevated white blood cell count, which you would assess doing a CBC. The treatment for pneumonia depends on the cause. If it's something bacterial in nature, it would be antibiotics. We do have a vaccine, as I mentioned, for pneumococcal pneumonia, which is recommended for people over the age of 60. If it's not bacterial in nature, you would give an antiviral prep to practice good breathing techniques and rest. Okay, one of the things that's happening with COVID-19, which, unless you're living under a rock, which you'd have to be. Thanks, Bren. For if you haven't heard about COVID-19, COVID is short for the coronavirus. It's lovely. You're quite an artist. I love it. Is coronavirus. Coronavirus, is just so everybody understands, is a family of viruses. It's not one single virus. Coronaviruses were at the heart of SARS, which was a severe acute respiratory syndrome that occurred several years ago. So one of the things that's happening to people with COVID-19 that are symptomatic is they are developing pneumonia. And the pneumonia can be so severe in some patients, and the inflammation associated with COVID-19, the inflammatory response of certain people's immune systems, is so severe that it's causing a massive fluid buildup in their lungs. And by doing so, that's what's requiring things like mechanical ventilation or inhalers in less severe cases for patients who have such severe difficulty breathing, which is why they're recommending, if people have mild symptoms, can stay home, but if they start to experience shortness of breath, true difficulty breathing, and pleuritic pain, that then it becomes a situation where you need to seek out medical treatment. Okay, tuberculosis. TB, tuberculosis. Okay, tuberculosis is a bacterial infection. It's caused by bacteria M. tuberculum, hence the name. It is the leading cause of death from a preventable, which is really sad, and curable infectious disease. TB is bacterial in nature, so it can be treated with antibiotics. But it is highly contagious. It is spread by airborne droplets, similarly to COVID-19. The bacteria are pretty hardy, they can survive, and then they can multiply within macrophages present inside of us. Okay, there are two different types of TB. You have latent TB, which means that a patient with latent TB is asymptomatic. Okay, meaning they have no symptoms, but they're carrying the bacteria, so they would test positive when administered a skin test for TB. However, it can develop into symptomatic TB, so it's people who have latent TB who perhaps want to go in a hospital. It would be a situation that you'd want to maybe assess it a little bit further. Symptoms of symptomatic or non-latent TB would include things like fatigue, weight loss, lethargic, night sweats, difficulty breathing, coughing up blood, significant chest pain. Now, the treatment for symptomatic TB, okay, as I mentioned, is antibiotics. But so you think, well, why is this such a problem? Then we're going to get to that in a second. So how is it diagnosed? They do a sputum culture. They can also do a skin test for TB, and those are pretty quick result types of diagnoses. Antibiotics can be used to treat it, control it, and prevent reactivation. So what becomes the problem with TB? Time. The course of treatment with antibiotics can last anywhere from 9 to 12 months that a patient would need to be on antibiotics, and those antibiotics have significant side effects. So people in all good faith will start their treatment for TB and then start to kind of forget, and then before you know it, they're not taking their treatment anymore. But they still have latent TB, or they still have the bacteria present. What is becoming a problem is because people aren't finishing their antibiotic treatment, is now we have multi-drug resistant TB. And I did have a student a couple of semesters ago who did test positive, had latent TB, wanted to go work in a healthcare facility, and they said, well, you have to take the antibiotics. And she said, I'm not doing that. It will take too long. So again, not that she meant any harm, but I can see her point. If someone had to be on medication for months and months and months and months with significant side effects for something they're not symptomatic for, that perhaps you're not really selling it at that point. Okay, the last thing I wanted to talk about, a couple of things I wanted to talk about were pulmonary things related to the vasculature. So we have embolism, a pulmonary embolism, and PAH, which is pulmonary artery hypertension. So pulmonary embolisms can occur usually as an embolization from a clot that's already present as a DVT involving maybe a lower extremity. So your patient would have a pre-existing clot, a DVT in a leg vein, for example, and a piece of that has fractionated and now is classified as an embolus, and that embolus is now winding up in the pulmonary system. Some of the risk factors associated with pulmonary embolism is immobility, okay? things like epithelial cell injury. People who are in a hypocoagulated state, there are certain disorders associated with hypercoagulability. Women on hormone replacement therapy, there's been a significant correlation between the level of estrogen that's administered with hormone replacement therapy and the incidence of blood clotting, including pulmonary embolisms. And then there are certain genetic factors. There's certain genetic disorders that are connected to developing blood clots, which would certainly put someone at risk for a PE. Okay, signs and symptoms: tachycardia, to even increased pulse rate, and difficulty breathing. Okay, how is it diagnosed? Pulmonary embolism is diagnosed, can be done by a CT scan, but more often than not, we diagnose a pulmonary embolism. They can do a VQ scan if there's, if it warrants it, but they'll do an arterial blood gas. An arterial blood gas is done by accessing blood from I had an arterial blood gas reading done. It was done on my radial artery. So they inserted a very large needle into my radial artery to extract some arterial blood to look at arterial blood gas levels. It left a really incredible bruise. It took a very, very long time to heal. They followed up my scan for a PE with a VQ scan as well. Treatment for pulmonary embolism is the traditional treatment you would look at for something like an anticoagulant therapy. So we think Coumadin, Lovenox, heparin. Okay. When we talk about the vasculature, we're going to talk about DVT and thrombosis in very general. We'll go into the pitfalls associated with things like Coumadin versus heparin versus Lovenox. Okay. But those are all viable treatments for a PE and for DVT as well. Okay, the last thing we want to talk about is PAH, or pulmonary artery hypertension. So remember, blood pressure in the pulmonary system is relatively low when you compare it to the systemic circulatory pressure. So when someone has PAH, and again, this can be correlated with COPD, which we talked about in the last couple of videos. Okay, what can it be? How does it happen? Okay, you can have fibrosis in the vessels that are servicing your pulmonary system. And when you begin to have fibrosis, you lose elasticity in those vessels. It drives up resistance to flow and it can increase pressure. Okay? Or you can have an increase in the workload of the right ventricle. If the right ventricle is pumping with great force, with greater than normal force, it's going to push blood under higher pressure into the pulmonary artery, and then again you'd have increased pressure then in the pulmonary artery. So how do we assess whether or not someone has pulmonary artery hypertension? They can do a right heart catheterization. You would notice fatigue and peripheral edema. Okay, you'd have edema on the right side because of the work of the right side heart. You'd have edema associated with that in your peripheral, in your extremities. And generally speaking, you would have chest discomfort. The treatment for this is you want to give diuretics. Obviously, if there's some outlying cause like COPD, you're already being treated for that. Oxygen and anticoagulant therapy. So again, there you're all about, when you're giving an anticoagulant therapy, to some degree, you're reducing that resistance to flow. And if we can reduce resistance to flow, you're going to reduce pressure. So again, if you're doing an anticoagulant therapy, you could do something like Coumadin, Lovenox, and heparin. Heparin can be given intravenously in a hospital. Usually it's done under some sort of medical provider's care. This is a pretty strong anticoagulant. This is the anticoagulant they put inside a heparinized tube to make sure that blood doesn't clot when you get blood sampled at room temperature. Coumadin is given orally. It has some issues associated with it in terms of regulating the dose and getting it to the appropriate level. Again, we do DVT. I'm going to talk about that more deeply. Lovenox is given through a subcutaneous injection. You're looking less at like PT and INR with Lovenox, but again, then you're dealing with the injection piece, right? Which some people aren't comfortable giving themselves an injection once or twice a day, depending on the dose of Lovenox that's appropriate for them. Okay, that's going to do it for changes in pulmonary function. I will be back when we go to discuss cardiovascular issues.